Hi, everyone.
Okay,
Yeah,
go ahead.
thank you for coming today. Yeah, no further ado, I will turn things over to Dr. Gundling.
All right, thanks. Already messed up the recording right at the beginning. But thanks for everyone for attending today. This is part of a series of a few other talks that we've put together here over the last year, all based on Zoom format, which has been nice, so people can kind of come and go as they please, and we can record as we are today. So these talks are all kind of based on common concerns and questions people have with respect to orthopedic care. So I'm a physical therapist. I work in Murraysville for Alliance Physical Therapy, and I see a lot of orthopedic patients that kind of across the spectrum of ability levels, with people, young athletes, some more elite athletes, and then people after total hip replacement, total knee replacement, people with balance issues, and kind of through that continuum of life. And the whole goal of physical therapy is to help us function better and do things that we want to be able to do and do them better, and maybe in less pain or with less difficulty at the very least. So that's our goal. And these talks have been a way for me to kind of share some of these common concerns and questions that I go over with people on a daily basis. So hopefully we can get more information out there so people can better steer their way through their own health. And that idea is specific to today's talk because it's about helping to steer you through your orthopedic care if you are in a scenario where you have some issues that you want to have addressed. So I have some common things that end up coming up as far as questions in the clinic when people are injured or have some concerns or have been identified by a physician or a friend that they may need to follow up with some orthopedic care. So the title of this is "A Picture's Worth 1,000 Squats," because the basis for so many years of orthopedic care has been the picture, right? The X-ray or the MRI. That MRI is like the gold standard. And if I don't have an MRI, then nobody knows what's wrong with me. So what am I going to do? I've got to get that MRI first. And then insurance companies come and say, no, MRIs are too expensive. We don't want to pay for them. So you need to find a different way to help yourself get better. And a lot of research, really good research that's out there, shows that trying physical therapy first can prevent the need for further diagnostic imaging, the expensive diagnostic imaging, and can really save the healthcare industry some money, which is good, right? We want to be frugal with our spending, especially in programs that are funded by the taxpayers and things such as Medicare. At the same time, though, when it's presented to the physicians, they hear it as the insurance companies dictating what they want what they expect me to do in the clinic. And I went to med school and they didn't, which I completely understand too, because they do the same thing to us in physical therapy. They dictate care to us sometimes, and that's frustrating because we've studied hard to gain the knowledge that we have, and then an insurance company comes and dictates to us, and we think, well, they don't see this patient in front of us, they don't understand this patient, which oftentimes is very true. The problem with that perspective is that then the physicians will say, okay, well, listen, I think you need an MRI, but your insurance company won't let me get you one until you try physical therapy and check that box. And then physical therapy ends up being, okay, I'll just go in, the patient sits down in front of me and they say, listen, I'm just here to check this box so I can get my MRI. And so then I'm starting as a physical therapist behind the 8 ball because the patient already believes that it won't help. And I haven't even gotten a chance to evaluate them yet. Now, it could be a scenario where they really do need an MRI, but very, very often, regardless of the area of the body, physical therapy is a really great way to enter the orthopedic care continuum. And that has led those findings and results, that a lot of them have come out of the of military studies. The government, the U.S. government, and the military uses physical therapists broadly across the different service branches with great success in maximizing maximizing the fighting strength of these battalions by just having a physical therapist kind of as a front end practitioner to be able to turn people right back out, get them feeling better and turn them back out, instead of sending them back to like out of the field hospital back to the main hospitals and causing a little bit of a slowdown in their return to battle. So they're finding this, they see this, and it is pretty powerful. And those findings have led to physical therapists pursuing more education along the lines of differential diagnosis and more imaging knowledge and things of that nature to get the doctorate, the DPT degree, and be able to see patients right off the street. So we don't need a referral from a physician in order to evaluate you in the great majority of cases in physical therapy. The exceptions are auto accidents and workers' comp accidents. Otherwise, we can at the very least, evaluate you and get that care started. So that was a long roundabout way of saying sometimes the imaging doesn't really tell us much, because really all that's showing us is the issues with the tissues, right? So it's showing us that we've got, in this case, on that left knee, some really nice space right there between the joint, and on the right knee, nothing. So when you see that, your orthopedic surgeon pops that up on the X-ray light, although I don't know really how much that happens anymore, but they pop that up and say, well, look at this. This is why you need a knee replacement, which that looks pretty bad for sure. That's some pretty narrow joint spacing. But each person's experience is different, and each person, just like we all look different on the outside, we all look different on the inside, and we all have our own little nuanced differences. And believe it or not, arthritis is considered to be a normal form of aging. It's just kind of something that happens as we get older, but there are cases where it can become painful and become too far degenerated for sure. So we have to be aware of those cases. But this person, even though it looks bad here over on this right side, might just not have any pain. So if they have any pain, should we do a total joint replacement on them? And the answer is no, because if they have no pain and they're not functionally limited, then why would we open up their joint and saw part of their joint out and then hammer in new pieces of fake joint? Because the new parts are never as good as the originals. The new parts don't have any nerve endings to tell us what kind of pressures are going through the joint and give us information back to the brain. And if you were on, was it last week or last month? I think last month's talk was on balance. And our balance, we operate on 3 systems, one of which is the somatosensory system, which is basically how our extremities talk to our brain. So they have a lot of pressure sensors that system uses. And we have pressure sensors in our knee joint and in our ACL and PCL, our ligaments of our knee joint. And in the case of a total joint replacement surgery, all of those are just taken away. So we take a lot of that, the ability to balance away. Now, in the case of someone that has a total joint replacement, we can work around it for sure. We can help other joints understand things a little better, but it's a little tough to really work around that, and it's not worth it if the patient isn't in pain. So these total joint replacements, it's important to know that the picture is not the whole story. It's how you feel day in and day out. And most orthopedic surgeons are going to tell you this. These days, it's pretty rare for an orthopedic surgeon, or if ever. I mean, I haven't heard of anyone doing this, any orthopedic surgeon encouraging someone to get a total joint replacement if they weren't in pain. Usually they'll tell patients something like, you'll know when you need this. So, when you get out of bed and you're in significant pain, you can come on back and we'll do it, which is very fair. That's obviously from the physical therapy perspective, I'm a little biased, but that's where someone should be sent to physical therapy in order to help with trying to push that day where they come back to the orthopedic surgeon out a little bit further. And by pushing that out, we're going to, in order to push that out, we're going to build strength and promote mobility in the joint spacing. And that can go a long way at minimizing need for physical therapy, or I'm sorry, need for surgery. This also applies in the low back or other joints of the body. And even when we have someone that has low back pain and they have an MRI done, and those findings are not extremely reliable as far as linking them to dysfunctions and issues. In fact, in populations without any type of low back pain, if we look across the age demographics, as we get up into our 50s, 60s, into the 70s, we start to see some pretty normal degenerative changes in the spine that we would usually think of as disease. However, they're pretty normal. And so remember, these are things that are in the non-symptomatic population. These people have no back pain at all. And if you are 65, then your risk of having, then of the 65, and people that are 65, that population, about 40% of them have a disc protrusion. So that disc is almost herniated. It's kind of just pushing and bulging a little bit out. A regular disc bulge, which is the one less than the protrusion, that population, 70% of people around 65 have that. Once you get up to 75, it's almost 85% of the population. Degenerative disc disease, if anyone has had an MRI done, they may have read that and it sounds scary. Well, if you're 65, then 90% of people without back pain have degenerative disc disease. So you would be abnormal if you didn't have degenerative disc disease at that age. So these are things to keep in mind whenever you get these images back from your imaging, that there's some normal age-related changes. Now, can these age-related changes cause pain? Yeah, they can. Just like this really mean-looking arthritis line here on this joint can cause pain, but it doesn't mean it has to. So there's a difference between what the picture is saying and what the body's saying. That's really important to keep in mind as you go through managing your own care. So what happens if we only focus on these issues with the tissues in orthopedic care, which has been a long time what we've dealt with? Well, we can find with cases of when we're managing low back pain, we can have poor outcomes when we're only focused on the issues with the tissues. We've got to focus on the person and how they move and what they expect, not just, well, this person has some degenerative disc disease and a disc bulge, so if their disc is bulging, we should prescribe them a cortisone injection and we'll see where it goes from there, something like that. We need to look at them from the perspective of, okay, this person, it hurts. And this is the physical therapist will go through the process of say, okay, it hurts when they bend forward, it hurts when they twist, they have a loss of range of motion here, and they have stiffness in the spine there. So we're going to do this mobilization technique. We're going to do some soft tissue massage. They need to work on strengthening their XYZ muscles. They need to work on these stretches. So we've got to come of it from a function perspective. Even if that same person has the disc protrusion or disc bulge, we may treat two people with the similar MRI findings differently because they behave differently in their lives. Oftentimes, like I was saying, if we're only treating based on the anatomy, then we're overlooking the person. So we need to know your name instead of your joint. And remember, these issues that we identify on MRI and in other imaging are just thought to be wrinkles on the inside, really. There's also waste healthcare funds. There's definitely an idea that kind of is a lot of people tend to come into the medical realm with the idea that, well, surgery will fix it. So let's just get surgery done. Like, let's stop beating around the bush here. Let's just go in and get surgery done and fix it. And that's really couldn't be further from the truth. I mean, there's plenty of information out there to say that just sticking a probe in a joint, sticking an arthroscope in a joint causes changes that aren't great. It can cause an increased risk for arthritic changes. It can cause an increased risk for lack of muscle activation around the joint and things of that nature. So just having surgery might not really fix it. In fact, it can add other issues. Now, there's cases where surgery is very necessary, without a doubt, and you should have surgery done in those certain cases where there's damage that can only be repaired that way. But a classic example is meniscus repair surgery. So your meniscus is in your knee. It's a little cup that basically helps to stabilize the knee, and we can tear our meniscus. And we can tear it in a few different ways with like a rotational force through the knee, falling on the knee. But sometimes we get degenerative meniscus tearing just because of the breakdown of the joint over time. They did a study of a few of people that had failed physical therapy. So they tried physical therapy, no help. No significant help, and they kind of fell into this study where they randomized the two groups. They all had a meniscus tear confirmed on MRI. One group they did the surgery on. The other group they stuck the arthroscope in and pulled it out. So they still had the surgical ports there, and they were never told whether they got the surgery or not. They were sent on to physical therapy. They progressed through their treatment program, and a year later, everybody got the same amount better, regardless of whether you had surgery or whether you didn't have surgery. So that's either an argument for sticking ports in as being the beneficial thing, which is unlikely, or a pretty powerful placebo effect. There's a lot of different ways to look at that, but regardless, it tells us that meniscus surgery is probably not necessary in anyone that has a meniscus repair, or a meniscus tear. There's certain people in the population of meniscus tears that definitely need surgery, but you can't just put a blanket over the entire population and say anyone with a meniscus tear needs surgery. That's really not true, but we don't have enough data at this point to really say who. It seems like it's pretty certain. We're getting better and better at saying that people that have degenerative tears might not need surgery, but people with traumatic tears where they fell on it might be more likely those good surgical candidates. And there's examples of that same exact process in the shoulder with your labrum, where they've done sham surgeries and people have gotten better. This we start to see kind of throughout the orthopedic surgery research, which is kind of like upsetting because doesn't seem like they're helping that much, but it's also empowering because it means the patients can have a little bit more to do with their recovery. And again, if we're only focused on the issues with the tissues, the pathoanatomical model of orthopedic care, and incite some fear and anxiety, which fear and anxiety increase pain. That has been shown time and time again in research. I read a paper when I was kind of in my training, and it was called Using Words That Heal versus Words That Harm. And it's very true. I mean, if someone tells you you've got the worst knees I've ever seen, then that's going to probably make your knees hurt a little bit more, and I don't know how many times I've heard patients come in and tell me that how my orthopedic surgeon says I've got the worst knees he's ever seen. And it's, I don't know how many times it's been from the same orthopedic surgeon, right? So like either each person that comes in is a little worse, or that's just something that they say, or saying things like bone on bone, right? Like that just sounds tough, like just grinding bones on bone. Yeah, that sounds horrible. Now, even if we look here, this is pretty close to bone on bone, but there's still some space there, right? We still have some space in that joint. So, and another thing that's important to remember is these images, as we scroll up, are two-dimensional images, interpretations, really, of a three-dimensional object. So we're only looking from the two-dimensional view. and say this person bent their knee a little bit, that may have a ton of cartilage right after that, where like as they bend their knee, they may expose more cartilage to the undersurface where the two bones here are rubbing on each other, and we may create some more space. It's hard to say, but remember, it's just two-dimensional. So it's not the most reliable way of looking at it. And another thing I've heard, like, someone that's in their 30s or 40s, and the surgeon says, "Oh, you've got the spine of an 80-year-old." Like that's pretty rough to hear. And it has a pretty significant psychological effect on you. Like, oh no, my spine's the spine of an 80-year-old. I better be careful. And really what you should do is move, get your spine moving, challenge yourself. And that's going to help make your spine look younger. So getting back down to it, the role of imaging in orthopedic care is to rule out acute pathology, fracture, cancer, dislocation. These are things that when you initially see whether it's your primary care physician, orthopedic surgeon, your physical therapist, they should be in their head ruling things out. Like, could this be a fracture? We have really, really reliable tests, things that we can do in the clinic to determine whether or not it's a fracture or not. So we can rule that out. Is it cancer? We have red flags for cancer that we know, pain at night, unrelenting pain, things like that, significant weight loss. These are things that we rule out in the initial evaluation. Dislocation, we can kind of look at the joint to see if there's any malalignments or any issues there. So we can rule these out with imaging. If all of those if there's no risk of acute pathology or very minimal risk of acute pathology, this is when we can jump into care as physical therapists. So we can jump into care, try to treat these individuals, and then if they're not getting better in about 1 to 2 weeks, or if symptoms are getting worse in one way or another, then we would consider further imaging for further diagnostics. Another reason to use imaging is to help determine the need for surgery, right? So yeah, sometimes people just need surgery and they're not going to get better until they do. But there are not many cases of orthopedic injuries that aren't like an acute fracture, things like that are extremely painful, that can't wait a week or two before having an image done and then subsequent surgery. There's not many surgeries that need to be done right away. There are some for sure, but your typical elective orthopedic surgeries, it's pretty rare that you need it done like right away. I'm talking like meniscus tears, rotator cuff tears, ACL tears, meniscus tears, we said that, MCL tears, Achilles tears, things like that. They don't need to be done right away. So here we need to look at shifting our perspective on injury, right? So we could see injury is injury equals functional limitation. So functional limitation here, oops, I missed. Functional limitation and or pain. It's not issues with the tissues. So it is functional limitation is the way we need to kind of look at injury. And that kind of helps change your perspective and understand where it would come from a care perspective for physical therapists. So we have, oops, there we go. So then as I put this talk together, it kind of led me to the thought that people might just have trouble understanding that continuum and how to progress through it. So this is something that I get these questions on a lot from when I do like community events, whether it's going to the YMCA and doing some talks or going to local races and things like that, where people ask like when and how do I enter the medical care model with an injury? When does it make sense? At which point does it make sense? And everybody has their own comorbidities and own issues that may lead them to enter sooner or later. But this is kind of the best model that I can put together. So The first thing you have to consider is the time, right? Depending on the severity, you would give it to, like 0 is probably more appropriate than 3 if it's extremely severe, but 3 to 10 days for healing. So, 0 is you fall and fracture your leg and you can't put weight on it. You should go to the emergency room in that case. Hopefully you would. But if it's a moderate injury, it's fair to give it 3 to 10 days. If you start to say you tear an ACL, initially you have some swelling, the knee feels okay, though you can't really move it much. Then you stand up on day 3 and try to step on it, and your knee buckles out from under you. Then you should go get some imaging done and some further diagnostics for sure. That doesn't necessarily mean jumping into surgery, but it means further diagnostics. If it's not that severe, then giving it 3 to 10 days for healing, see where it ends up, and then a great place to start your orthopedic care model is in physical therapy. And the reason is because, like the reasons that I outlined before, we've been trained in differential diagnosis, pain management, building function, using modalities and things to calm down pain. And we have the ability to treat you right away, right? If you were to go see your primary care or another physician, sometimes you're going there to then get the referral to go to physical therapy to start your treatment. So this just gets you right into the system, right into treatment. And that, I think, is the real benefit of seeing physical therapists.
Okay, now.
First. Yes.
Oh, I think that was the audio recording again. Sorry.
Oh, okay. So trying to get you in relatively early, and the reason I wouldn't push it too far beyond 10 days, maybe 20 days after your initial injury, is because we have a lot more difficulty calming things down the longer you wait. So it's not to say we couldn't get it to go away completely someday, but it will take longer the longer you wait to get it treated. So somewhere in like that 10 to 20 day mark is really good.
Yeah, no, it doesn't.
To get you going forward before things get too bad and too hard to and get more difficult to manage. So when we look at physical therapy, we break it up into phases. Phase 1, when someone is recently injured, is we basically want to promote blood flow to the injured tissues and reduce pain, control pain. I think next month or 2 months, I have to look, I'm going to talk about inflammation. And inflammation is a really, really important component of healing. We look at inflammation as a bad thing usually, but we want inflammation to happen early on because that's bringing nutrients to the area. And we can talk more about that either next month or the following. But in physical therapy, we're initially going to probably try to promote some blood flow, unless the inflammation is really out of control. We want to keep blood flowing in and new flowing in and old blood flowing out, new blood flowing in, old blood flowing out. Keep that tissue turnover so that we get more nutrients. And we want to help you control your pain and get you more under control there. Then phase 2, we're looking at improving function and returning to activity. So if now your pain is hopefully decreased, we can start to build your function and the things you're able to do throughout your day. Start to work you back into your normal daily activities and progress from there. We'll progress to the more aggressive daily activities, and then phase 3, we would consider how we can prevent future injury from occurring. So those future injuries can be managed by developing strength and mobility in the areas that maybe you didn't have before, which caused you to have that injury in the first place. That's not always the case. Sometimes it's just a traumatic injury, but we want to make sure that we're not. We want to make sure that you come out of physical therapy better than when you came in. That's not always possible, but we want to work with you to get as close as we can. And that would look something along the lines of initially, we would probably see you relatively regularly in that phase 1, because we've got a lot of things we can do hands-on to help you feel better. And then phase 2, we may decrease that frequency. Phase 3 may even decrease it more to a point where we see you like once a month once every 2 months. Let's just check in and make sure you're still progressing with your home exercises. We may need to change some things. So if you're going through physical therapy and you're not getting the results you need, then a good next step, as long as you're not a clear surgical candidate, is to consider non-operative orthopedic specialists. And those often are in the form of physiatrists, or sometimes sports medicine, primary care physicians, or even your primary care physician itself, depending on their knowledge level in the musculoskeletal orthopedic realm. So they kind of take things to the next level where they have the ability to order diagnostic imaging, prescribe pharmacological therapies, and try to control your pain in ways that way. If we're going to talk about some of the different things they do specifically, you've got initially a lot of people will rely on NSAIDs, right? So those are non-steroidal anti-inflammatories, and those are like your ibuprofen or Advil, and Motrin, Advil and Motrin or ibuprofen, and then Aleve is naproxen. So these work by building up in your body in order to have an effect. So these things shouldn't just be taken in response to pain. Oh, I hurt today, take Advil. If you want to have an effect on inflammation, they have to be taken regularly and at a dose that will affect that. So that's something important to keep in mind. Pain management is something you can do in response to pain. So that's acetaminophen or Tylenol is probably the most common form of pain management. And that's a great way to help control your pain. Medical cannabis is becoming more and more popular in this realm too, which can be really effective. Usually those are for more long-term chronic pain issues when we get to medical cannabis. Corticosteroids they can either be injectable or oral. They can be injected to the site of injury. And they can be extremely effective at decreasing inflammation. So like NSAIDs, pretty good at decreasing inflammation. Corticosteroids basically like wipe it out. But they come with a lot of side effects. And again, remember, inflammation isn't necessarily a bad thing. So we wouldn't want to like wipe it all out right away. We want to help it, be inflamed for a while and turn over these tissues. And the injectable corticosteroids have some links to degenerative changes in joints. So we want to be leery of that and try to minimize the amount of injections we get. Some are fine, but if you're getting them on a regular basis, you're steering yourself in the direction of some pretty significant joint breakdown, very likely. Then taking oral steroids, you've got a lot of side effects from the perspective of just weight loss, but all the way up to bone mineral density loss, where you're at increased risk for fractures and osteoporosis, and a significant host of other disorders there. So you want to be leery of taking that on a regular basis. In the orthopedic world, typically corticosteroids are used in like dose packs. So you get a pack of 10, you take them on a tapered dose over a few days, and that can be effective to decrease inflammation. So those are all the things that are like the traditional management techniques for issues in the medical world. But you can see all of these things, right? All of these are really focused on treating your symptoms and not your injury, right? They're just focused on treating the inflammation and pain. They're not focused on helping the injury feel better, which that's where we get into, let me get rid of that. That's where we get into the realm of, well, first of all, we're into it with physical therapy. Exercise helps heal tissue for sure. But then when we come to medical management from a physiatrist or PCP perspective, we get into the regenerative therapies, which are these starting with prolotherapy and going down here to the stem cell injections. Prolotherapy is a sucrose solution that's designed to irritate tissues and restart the healing process. So a lot of times when we have chronic issues, that healing process can get stalled out or delayed. And as a result, we end up with someone that's just not healing. They're kind of stalled out. They're not improving. Exercise can do a lot to help start to push that process of regenerating the healing. I mean, we exercise tissues in a strange way to re-injure the tissues so that it can then heal the tissues better than they were before. Sometimes the prolotherapy injections are thought to really have a positive effect on being very specific to the injured tissue. You can use ultrasound guidance to get right in on that tissue and kick off a good healing cascade. Platelet-rich plasma is kind of the next level up from prolotherapy. This is how I like to think about it, and it makes decent sense to patients as well, where when we have the sucrose solution, the prolotherapy, we irritate it to bring nutrients to the area. The platelet-rich plasma injection is basically taking those nutrients, the most nutrient-rich part of your blood, spinning it down, getting just that plasma, which is super nutrient-rich, and injecting it right into the spot. So we're kind of short-circuiting that process of inflammation first, then nutrients, and we're just going straight nutrients. And that can optimize the healing environment. Then the next step is stem cell injection, which was at one point thought to be something where we inject stem cells into the area. How you harvest them is dependent on a lot of things, but stem cells can become any cell. And the thought was we inject stem cells into an area and they become the cell of the injured tissue. That's really unlikely to be the case from the research that I've seen. And what's probably happening in the times where it helps is that, again, it's similar to the platelet-rich plasma, where it's optimizing that healing environment. There's a lot of nutrient-rich stuff in that stem cell injection, and it helps bring nutrients to the area. Then we would consider the idea of orthopedic or neurosurgeons in these cases where things just aren't getting better. You know, you've got cases where you have a tear or an issue or a significant disc herniation that just needs to be addressed. And that's when you go see your orthopedic surgeon. Again, they're not all created equal, but generally orthopedic surgeons like to do surgery. That's why they got into it, right? So they are really good at surgery. They're experts, and it's super complex, high-level techniques that are specific to joints. Even your orthopedic surgeon you don't have like a general orthopedic surgeon anymore. You've got a knee surgeon, a shoulder surgeon. Like that's all they do. That's how specialized these techniques are, that they're that specialized that they need to be that specific. So that's where using physical therapy or physiatry or primary care physician is so helpful early on, because it takes the load off of the surgeons. The surgeons, they would much rather see an extra day of surgeries than a day in the office, most likely, of seeing patients. So the more surgery specific clients they get, the happier they'll be, and the more efficiently the orthopedic care model will be used. So there's definitely a case where you need this, but I wouldn't rely on it. And oftentimes in Pittsburgh, there are a lot of orthopedic surgeons, a ton of orthopedic surgeons, and they're often thought of as like the pinnacle of knowledge on a specific joint. In a lot of ways they are, but the problem is a lot of times issues aren't just one specific joint, So knee pain that has developed slowly over time isn't just knee pain. You have weakness in your hip, weakness in your core, issues of stability in your foot. You can have any host of these other issues that sometimes when orthopedic surgeons are focused just on that knee, they don't have the time to look up and down. So that can be something that is overlooked. And that's where other healthcare practitioners can come into the model and help out a bit. I'm not by any means saying that orthopedic surgeons are something that you should avoid, but you should like to avoid them, because if you go to them, that's when you probably will need surgery. But it's something that is definitely a part of the medical model. And then other considerations. I mean, there's all kinds of different considerations to make, other types of therapies and modalities to help with chronic issues. One that I really like to point my patients towards is a dietitian, and they can help with weight loss and management of inflammatory conditions. Like chronic inflammatory conditions can be addressed well with that, and weight management. I mean, if we think of the knee joint specifically, 1 pound of weight lost out of your body is about 4 pounds of weight out of your knee. So that has a pretty significant effect on the function of your knee. If you can lose 10 pounds out of your body and then 40 pounds out of your knee, that's a huge amount of weight. that can really kind of flip the script on how you are going to improve. So this is something that can't be overlooked, how important your diet is. And when it comes to weight loss, really 80% of your ability to lose weight is based on diet, and 20% is exercise. And that's coming from someone that really likes exercise. So that's something really that can't be overlooked in those cases. So just kind of quick reminders as we went through that traditionally I would just be leery of those practitioners that give you the idea that all of your issues are based on your anatomy. That's kind of an old school way of thinking from an orthopedic perspective. So be leery of that, and also be leery of practitioners that are really confident that they can get you better in like just real quick, like, this will be easy. That's someone that people typically, when you're being overpromised something, it is too good to be true. It takes work. It takes work to get better. Even if you have the surgery, it takes a lot of work afterwards. So you've got to be willing to earn your health and build up a good fortress for your body, just so that you can keep doing what you want to be doing for years to come. So here's some information on our offices. We have an office in Penn Hills and Murraysville. Remember, hopefully you remember this from this talk at least. Whoa, wrong, hold on. I wanted a highlighter. No referral needed to come to physical therapy. So you can come in and be treated pretty easily and quickly from our physical therapists or other physical therapists, depending on where you live. Okay, so we can open it up to some chats here, questions. So feel free, you can ask questions, or you can ask questions through the chat function, or you can just unmute yourself and ask that way.
Okay. So one question I have, you mentioned the importance of, weight loss as regards joints, and you said, primarily a lot of that is diet. When you are exercising, what are I guess the initial warning signs, maybe that you might be overusing your joints?
Yeah. So the body uses pain as a communication device. So it's pain is what our brain uses to tell us, like, hey, I think we've got an issue down here. And so you've got to just be aware of pain that persists over. Pain has a few different characteristics. It has how intense it is and how long it lasts are probably the two most important things to keep in mind. So pain that's really intense during exercise, that's bad. Like if it's above 5 out of 10 on our little 0 to 10 pain scale, that's something that you should say, okay, this is that we need to consider having someone address this. And then if it is maybe only a 3 out of 10 or a 2 out of 10, but it lingers around for a long period, like days or even a week or so, that's when we would consider, you should consider getting in and having someone look at it. So that's that in that 0 to 14 to 21 day span of time where you've got to consider getting someone to look at it if it's really lingering around and not getting better. So those are some good things to keep in mind.
I have a question. What exactly is osteoporosis?
So osteoporosis is a breakdown of the bone mineral density in your bones. So basically your bones are getting more frail and weaker and have more potential for fracture. So most commonly that can happen in some of the spinal bones, your vertebral bodies, and also the bones of your hip, like your femur. The most risky scenario would be like the neck of your femur could fracture and things like that as we age.
Now, are you more likely to get it if you're smaller and you're not putting weight on your, I don't know how to explain that.
Okay, so yeah, what you're kind of referring to something that's called, it's called Wolff's Law, which is the more stress you put through the bone, the stronger the bone becomes. And you're saying if someone doesn't weigh very much, then they're putting less stress through the bone, and then they could have weaker bones. Is that kind of what you're saying?
Well, that's kind of the way it was explained to me.
Yeah, no, and I've not thought of it like that, to be honest. And I don't know of any information that says like that is a risk, being small is a risk for osteoporosis, but it makes a little bit of sense. It does. But that highlights the idea of weight-bearing exercise being extremely important to prevent and even manage osteoporosis. It's hard to regain bone mineral density back after you've lost a significant enough amount to be considered osteoporotic, but it's a great way to manage it and limit the progression.
Thank you.
Yep.
Okay, if no one has any final questions, I think we'll start to wrap up for today. As always, if you would like a copy of the handout, you can email me or email Colin. I'm going to put my email address in the chat function right now.
I'll put mine into here. There we go.
Okay, yeah, so feel free to send either of us an email if you have additional questions, or, you know, even if you have ideas of things you'd like to see addressed in the future. Those are things we can consider. And hopefully this video should be up this week on our YouTube and Facebook pages. So if you would like to revisit it, feel free. Thank you very much for speaking today, Colin. Very appreciated.
Absolutely. Thanks for having me. I appreciate it.
Have a nice day, everyone.
Bye-bye.